everybody. Welcome back. For the next, probably about the next hour, we're going to jump into really the nuts and bolts of the actual legal work that you're going to be doing, the substantive laws and the regulations that kind of govern and frame this oftentimes confusing world of VA benefits. And I'm going to start by talking about the three elements necessary to prove and get service connection and service-connected benefits. So there's a large set of laws and regulations that govern the work that we're doing. Some of these are going to look familiar to you. Some of them are most likely not. Some of the more familiar ones, all of the statutes and regulations governing this live in the U.S. Code and the Code of Federal Regulations, 38 U.S.C. and 38 CFR. There's also obviously case law involved in the work that you're going to be doing. There are many cases that are heard at the Board of Veterans Appeals, which is actually the highest appealable level within the actual Veterans Administration. Those cases are published, however, they're not precedential. That being said, you can appeal out of the BVA to the Court of Appeals for Veterans Claims, or the CAVC, which is actually its own federal district court. Those cases, for the most part, are precedential, and you can find them on Westlaw and Lexis. We will most likely not be taking cases that far to the CAVC, and we'll explain why later. That being said, CAVC cases undoubtedly will frame and influence the briefs that you'll be writing. And then some of the stuff that's probably not going to look familiar to you that's a little bit more VA specific when it comes to governing law. The first is the VA Claims Adjudication Manual, or the M21. This is essentially the guidebook or the handbook for the appellate judges or the lower level decision review officers that are deciding the claims. It is essentially a very kind of practical step-by-step interpretation of the codes and regulations, but more practical in the sense that it's what these decision review officers are actually looking at when they're deciding the claim. So probably not something that you want to spend a ton of time citing to in a brief necessarily, but something that if you were going into a hearing, you would want to familiarize yourself with the relevant parts of it, because that, for better or worse, is what these officers and these appellate judges, I keep saying appellate, administrative law judges are going to be looking at when they're deciding the claim. A couple other, areas to look at are Office of General Counsel, or OGC, precedent opinions, and VA fast letters. Important to know really kind of what the distinction is here, and I can give examples. OGC opinions are essentially clarifying. It's the general counsel clarifying existing law and regulation. So there's an OGC opinion that you might end up looking at that does a kind of much more thorough job of defining what a combat veteran is than the VA regulations do. And then, by contrast, there are VA fast letters, which are actually expanding kind of what the law is rather than clarifying it. So a pretty common fast letter that you may see is one that creates presumptive service connection for tinnitus or ringing in the ears or hearing loss based on what your occupational specialty might have been. And then, again, recommended book or treatise that we use on a pretty regular basis is the VBM, or the Veterans Benefits Manual, that lays out kind of step-by-step all of the kind of relevant issues, not just in disability benefits, but also in eligibility for other VA benefits like health care, home loans, GI Bill, things like that. But I want to talk more about kind of what's going to be most relevant to you in working on these cases. And the first thing you'll need to determine in working with your veterans, especially if you're meeting somebody for the first time or going to an intake, is whether or not they are a veteran for purposes of eligibility for VA benefits. You really need to meet two general requirements that get a little bit more confusing as you jump into them. But the first is that the veteran must have had active military service, and then the second is that they must have been discharged under conditions other than dishonorable. I'm going to unpack what active military service means and then talk about the discharge status and how that affects benefits. So the active duty requirement, really this breaks down into pre-1980 and post-1980. If you're working with somebody that served before 1980, it's pretty straightforward. There is no length of service requirement. Pre-1980, if you served on active duty for really any period of time, but generally 90 days, with at least 1 day during wartime, you will qualify as an active duty veteran. Post-1980, it gets a little more complicated. You need to have served at least 24 consecutive months or for the period that you were called to active duty. So for folks that are on the reserves or the National Guard, you might have been, not on active duty, but called to active duty for a year-long deployment. If you complete that year-long deployment and go back to the reserves, you would still be a veteran, even though you didn't serve the 24 consecutive months. Okay, so that's the active duty requirement. Now talking a little bit about definition of a veteran as it relates to discharge status. So the document that's really going to be the most important for you all, at least as you kind of jump into these cases to kind of get the lay of the land, is the DD-214. This is the document that every service member receives when they discharge from the armed forces. It is an important document in the veterans community. If you ask them for this document, they may not have it, but they know what it is, and they know oftentimes what it says and can get it for you. You can also request it. We'll talk a little bit more about how that works later. And obviously, in the cases that you guys will be getting, we'll have done all the records requests already. But an important document to know, first and foremost, because it tells you what the veteran's discharge status is and what they may or may not be eligible for. So what is this under conditions other, what does this under conditions other than dishonorable mean? There's a variety of different discharge statuses that a veteran can get when he or she is leaving the service. And they range all the way from an honorable discharge down to a dishonorable discharge or a dismissal. Let's see. So for the most part, veterans with an honorable discharge are eligible for any VA benefit that there might be. They may not necessarily qualify for it, but their discharge status will not bar them from it. Veterans with a general, veterans with a general or an under honorable conditions discharge are going to qualify for the service-connected disability benefits that y'all will be working on. The only thing that they will not qualify for is the GI Bill. Where it gets a little more complicated, and I don't think that either of the two cases that we're placing today have a bad discharge in it, but this is important just to flag for you in case this comes up later. We obviously will be happy to kind of work you through it, but it boils down to veterans with OTH or bad conduct discharges, so kind of like those two levels right there. The VA has to make a separate determination based on the quality of their service, whether or not a veteran with an OTH or a bad conduct discharge qualifies as a veteran. That's almost its own separate area, not area of law necessarily, but its own separate legal analysis within these claims that gets particularly complicated, not in large part because the VA so often screws this up. So if in the future you guys get a case where there is an OTH discharge, especially if the VA has denied that veteran status because of it, you can appeal that and oftentimes win because, like I said, they've screwed it up. But we can obviously talk with you in more detail about what that looks like. A practical consideration here, we're talking about the definition of a veteran for VA benefits and what the VA considers a veteran. All of the folks that I work with that served in the military and no longer serve in the military, we call them veterans. They are veterans to us. Whether or not they qualify under this definition, and frankly, whether or not they do may depend on our advocacy. So it's just easier and frankly more respectful to just call the people that you're working with veterans regardless of how the VA technically defines them. So I was hoping you guys can jump into the handouts. There should be three, right after the accreditation paperwork, 3 examples of DD-214s. This oh so important discharge document. Does everybody find where we are? Okay, great. So take a minute to look at the first one. I'll run through kind of just the nuts and bolts of this, and then we'll go over a few questions. So as you can see, there's kind of a lot of information packed onto this page. and it may not be immediately obvious kind of what you're looking at until you dive in. So as you can see, real basic stuff at the top, and then, there's other things that are important here. You've got, in box 11, you've got that military occupational specialty, or MOS, that we're talking about. So this veteran was an infantryman. Over on the right, in box 12, you've got the dates of their service. Down below, in box 13, you have the different awards and medals that they received. Important to note here, oftentimes that box is incomplete. And even if it is complete, a lot of these medals that they've received for specific things that this document doesn't do justice to what exactly they received it for. If you're trying to prove things like combat status, say for a post-traumatic stress claim, I find it helpful to ask them about these medals, because it not only will help maybe be an entry into talking to them about their service, but they also may have the paperwork that kind of expounds on this a little more. So, for example, you might see let's see here, like an Army Service Ribbon or an Army Achievement Medal. It just says Army Achievement Medal. That could mean anything. But the paperwork that your veteran may have, or that may be somewhere deep in their file, will show exactly what they achieved or received that achievement medal for, which, as we'll talk about later, could go a long way to proving, the combat or the trauma that they experienced in service. What's missing here in this document? Is there anything that jumps out to you that, based on what I've just talked about, that probably should be here that isn't? The discharge status? Yeah, exactly. So this is a short form DD-214. Don't get nervous. Don't freak out if a veteran hands this to you, or when you jump into his or her file, you don't see the discharge status on the DD-214. The files will have both a short form and a long form DD-214. You'll figure out what the veteran's status is, or the veteran's discharge status is, even if kind of the first things you look at don't have it. What else jumps out to you here? Where did this veteran serve? And how many deployments did he or she do?
I served in Iraq.
And Afghanistan.
Yeah, and it looks like 1, 2, 3, 4, 5 deployments. This, I think, may be a bit kind of shocking and surprising to folks, especially maybe folks that are a bit older and more, had more of their either direct or indirect experience with folks that went to Vietnam. Typically, they went deployed for one deployment, maybe two, and it was for a year or less. That has changed, unfortunately, for a lot of the folks that have deployed more recently. We are more and more often now seeing folks that have done 2, 3, 4, 5, 6 deployments, and were often stop lost, or in other words, held over longer than their initial enlistment. And that's, I think, important to know and talk about, because it could have a direct impact on the stressor statements that you're doing with them, or the claims that they have for the disabilities that they incurred in service. Okay, let's jump into the second one. So in looking at this veteran's DD-214, let's say you're working with him on a service-connected case, and again, we'll dive into the elements of this more in a minute, for post-traumatic stress. What do you think, just based on this document, would be some of the evidence that you would want to use in your brief, or some of the things that you'd want to get more information on based on what you're seeing here?
And the Purple Heart, right.
Yeah, absolutely. The Purple Heart and the Combat Action Ribbon, we'll actually talk about this a little bit more, but receipt of those by themselves, the VA is going to concede exposure to trauma for a claim for post-traumatic stress, for example. So at that point, really in this case, you've done, putting the cart before the horse a little bit because we'll get into the elements, but you don't have to focus so much on proving what happened as you do on helping that veteran maybe get the treatment that he or she needs to show their current diagnosis and their symptoms. So, potentially a shortcut for you in a case that you might be working on with them.
Is there a manual somewhere that tells you, like, okay, if you have a Purple Heart or combat, you're automatically they're gonna concede exposure to? Because I don't know what all of these medals mean.
Oh, absolutely. So I think we'll talk about this in more detail later, but as a general rule, in working with us, there's the Veterans Benefits Manual, which is like a great treatise to have that gives a general overview of all this. That being said, we also are going to provide you with supplemental materials, a brief bank, kind of examples of the cases that have these most common issues in them. So, much more than what this 3-hour training can provide. There's quite a bit of background on what some of those kind of presumptive conditions look like when it comes to different metals, as well as a lot of the nuts and bolts of this in more detail.
Just to be clear for everyone, Purple Heart is you were injured in action.
Yes, absolutely. Yeah, sorry. Thank you for clarifying.
I come from a whole family military.
Yeah. Okay, let's jump into the last one. So again, these last two were both folks that served during the Vietnam era and actually both deployed to Vietnam. But a couple important things here. There's kind of an egregious error in this last DD-214. Can anybody spot it?
Discharge, but it says drug use.
True, and that's you pinpointed what I was going to talk about next. That's actually not an error, and I'll explain kind of what happened there. But it's a little bit more detailed. So see his date of birth in box 5.
Versus the year and the day.
Oh yeah, which actually that's the military goes year, month, day.
His birthday is 1971. How could he be a Vietnam vet?
Right.
In 71.
Right. They put his the date he entered active duty is his birthday. He would be zero days old given this. So I think that's just to show you that although this document is incredibly important, it doesn't mean that it's not perfect, or it doesn't mean that it is perfect. And unfortunately, sometimes these are riddled with errors. So it's important both to use this as a starting point, but also realize that you're going to have to dive, considerably deeper into the veteran's personnel file and their service treatment records to see what's really going on. You brought up the point about the honorable service with the drug abuse narrative for separation. That actually, and we're not going to talk about discharge upgrades much here, but that was actually a result of class action litigation filed on behalf of a large number, really all Vietnam-era veterans that were discharged with a bad discharge for drug abuse. At the time, especially towards the end of the war, so we're talking again here like the early to mid-'70s, as they were downsizing troop numbers, they were looking to get people out as quickly as they could because they didn't need the service members as much as they used to. And so a lot of folks were getting discharged very quickly for one instance of substance abuse, one positive drug test, without an opportunity to go to any sort of drug or alcohol rehabilitation or counseling, which they were entitled to. And so oftentimes you'll see on a lot of veterans DD-214s from this era, especially towards the end of the war, discharge statuses that unfortunately still show the narrative reasons for separation, but have been upgraded to honorable because they weren't afforded that opportunity for rehabilitation, especially in coming back from deployment. So that was really just to give you all kind of a starter look at what some of these records can look like, and specifically what the DD-214 can look like. You'll obviously, be working with this document and others in the personnel files as you dive in. But I want to talk now about kind of those three elements that I queued up earlier. In order for a veteran to be eligible for service-connected disability benefits, he or she needs to be able to show three things. The first thing he or she needs to be able to show is that they have a current disability and that they're receiving some sort of treatment for that disability, whether that's residuals from an ACL tear in their knee or post-traumatic stress or traumatic brain injury or hearing loss. They need to be able to show that they're disabled in some way. The second thing that they need to be able to show, and this is often where the rubber meets the road in the work that you all do, is that something happened during their time in service. An incident, an event, an injury, a manifestation of a disease or a disability, but there's something that happened during the time in service. And then the last thing that you need to be able to prove for the veteran that you're working with is that there's a nexus or a link between what happened in service and the disability that they're dealing with now. And I'm going to unpack all of these in considerably greater detail moving forward. So again, the current disability requirement is oftentimes the least difficult element to prove, and really kind of the starting point for the case. A veteran's coming to see you because something's wrong. They have something that's making it difficult for them to work, difficult for them to lead a healthy life. That being said, this can be more difficult with veterans who are dealing with complex mental health diagnosis, oftentimes with overlapping symptoms, or who are dual diagnosed, which means that they have a mental health disability and maybe self-medicating with drugs or alcohol, or just have a history of drug or alcohol abuse in addition to a mental health diagnosis. It's not to say that you can't work with them, but it means that there might be a little something extra that you need to figure out. I know that a lot of the veterans that I've worked with, especially on first meeting them, even folks that are maybe seeing a psychologist or a social worker, I'll ask them about this, ask them what they're being treated for, and they say, I honestly don't know. I just see Dr. Smith twice a month. I don't know. And so at that point, it's your job and it's our job to request those medical records. And spoiler alert, it would be anyways, and you're going to review them anyways. But you may need to do a little bit of digging to figure out exactly what the disability is that you're going to be working with and trying to get service connected. Okay, so where it gets a little bit more complicated, that second element, which is evidence of an incident, an event, or injury during service. Any incident counts, and I can't stress this enough, that really I want you to be able to think about this kind of as broadly and really as creatively as you can. An example could be a combat-related injury, like something that you got a Purple Heart for. It could also be a non-combat related injury, like playing football, injuring yourself maybe in a car accident while you're on active duty. It could be contraction of HIV or any sort of other illness during your time in service. It could be something related to a rape or an assault that a veteran experienced in service and are now experiencing, whether it's post-traumatic stress or another disability related to military sexual trauma. It's also important to understand what the burden of proof or the standard of proof is in these cases. The standard of proof is as likely as not, which is probably a standard that you're not typically used to dealing with. It's certainly lower than preponderance of the evidence. It's lower than beyond a reasonable doubt. It's really 50-50. You do not need to prove with any level of absolute certainty that the event or the incident occurred in service. But you need to be able to show that it's as likely as not that it did. So Melissa's going to talk, quite a bit more about, service connection for post-traumatic stress. But just to kind of give you an example of what that looks like here with the burden of proof, if you had a veteran, that was in combat and his or her vehicle was hit by an IED and maybe they lost a fellow soldier or a fellow Marine in that attack. You do not necessarily need to show irrefutable proof that they were in that vehicle on that date and in close contact with the person that passed away or that they were injured in any substantive way. But you do need to show something, and that something could be a news article talking about that blast or something about their unit showing that they were in the vicinity at that time, or a statement from a veteran, a declaration, or what we like to call a stressor statement, where they detail what happened, give dates to the extent that they can, anything that can kind of place them in the vicinity of that event in service. So again, I think that this element in particular is kind of where our creativity as attorneys and and advocates working for veterans can really kind of come in and help make the difference between, a claim that might, be stuck in the mud and one that we can really kind of move forward in thinking creatively about this incident or event in service. I think it's helpful here also to talk about, hold on one second. Yeah, I think it's helpful here to also talk about the fact that this doesn't necessarily, although it often is, have to be some sort of triggering event. I mean, when we think about post-traumatic stress, we're often thinking about a traumatic event happened and now the veteran has PTSD or PTS. And that's a perfectly acceptable and fine way to prove service connection, but there doesn't necessarily have to be something happen. There doesn't need to be a triggering event. I can't tell you how many veterans I work with that have, manifested severe mental health issues in service. Schizophrenia being a big one, especially for men who tend to, if they're going to manifest that disability, tend to do it in their late teens and early 20s. When folks tend to just be entering the military, especially if they've enlisted. You don't have to show that something happened to cause their schizophrenia, but if there's elements in their service treatment file that shows that, maybe not a diagnosis, but that they were, starting to receive treatment for an adjustment disorder or some sort of mental health disability, that's fine. That's enough to prove an incident in service without having to prove any sort of trigger or kind of causal connection. So again, like I said, important to really think about this element as broadly as you can. So why such a broad policy? A couple reasons. Service members can't have private insurance. There's no workman's comp system in place. And really this was Congress wanting to make sure that veterans had a safety net for people that had, enlisted or, were compelled into duty to serve our country. And so again, there's a broad policy here and we want to be able to kind of lean on that broadness as best we can to be successful in our cases. So I want to talk about this last element now, the nexus or the linkage element. This is showing that there's a connection between what happened in service and the veteran's current disabilities. Nexus is often proven in three ways. Obviously, the most straightforward way would be onset of that disability in service, like in that schizophrenia example that I was talking about. If the veteran was diagnosed with schizophrenia in service and has schizophrenia now, your case is pretty much, done for you. That being said, if that was the case, it probably wouldn't be getting to us. Ideally, that would be a case that was service connected with, without the need to have to take it to appeal. So typically the way that we end up having to work to prove nexus is through direct medical opinion or onset of the disability during a presumptive period. And I'll unpack both of those. But again, first, onset during service. Obviously, treatment during service is the best way to do this. However, it's also the least likely to happen, and in particular for veterans who are dealing with mental health issues, oftentimes during their active duty service. Any ideas why that might be so unlikely? That a veteran that you're working with who, from what you can tell and from what he or she's saying, started manifesting mental health in service, wasn't diagnosed, or didn't get treatment? Any ideas why that might be the case?
They didn't want to report it.
And why not?
You get kicked out of it.
You get kicked out, it's embarrassing, and back in, even back in the early 90s, they just didn't talk about stuff like that.
Absolutely. And I think as a society, we probably didn't talk about it. And I think in the military, it's that like times 10. There's certainly, depending a little bit on, where you're stationed, what branch you're in, there's a sense that if you're dealing with it, you deal with it on your own and you get back to whatever it was that you were doing. And I think you're right. The very practical consideration is if you start talking to somebody about this, the very real truth is that your days in the military are probably numbered at that point, which is, not what any of the people that we work with wanted when they enlisted in the first place. Any other ideas why?
Well, you're in such an abnormal situation to begin with, being, particularly if you're in a combat zone, and if you're manifesting unusual behavior, it might not seem so unusual in that situation.
Right. Yeah, I think that makes sense. And you also hit on a real practical point is if you're in a combat zone, there's probably not a psychologist or a psychiatrist stationed at your forward operating base who is holding regular therapy sessions. So you're absolutely right. Any other reasons, and I've got a particularly cynical one with a particularly egregious example, but I want to see if anybody's got any other ideas. So we've run across this in a variety of different contexts, but I think that whether it's spoken or unspoken, when folks are discharging from the military, there is a desire to not pay out, to not be on the hook for paying these folks disability benefits. I'm working with, and have now for a couple years, a veteran who was diagnosed with schizophrenia in service. He served in the early 80s. He was in for about a year and a half. He started manifesting some pretty severe symptoms, and was about to be discharged with schizophrenia, and paid out for that disability because it very clearly was incurred during service. In his personnel file, there was a letter from, I don't know if it was his direct commanding officer, but somebody up the chain who said, I see that you've diagnosed this veteran with schizophrenia. We also have evidence that he's been using psychedelic drugs during his time in service. I need you to change his diagnosis to acute psychosis caused by drug abuse, because I think that's going to be more financially expedient for the military. It said that in his personnel record. Oftentimes you don't see anything that egregious, but I think that that's an example of what oftentimes is happening behind the scenes. You get folks that may be dealing with very serious mental health issues that are often played off as, in this guy's case, drug-induced psychosis, or what we see in our kind of more recently discharged veterans, a personality disorder diagnosis or an adjustment disorder diagnosis. That's important because personality disorder and adjustment disorder are not pay-outable. I can't think of the word, but the VA doesn't pay for service connection for those things, when they may actually be more correctly diagnosed with PTSD, and often get diagnosed with that after they've discharged. So again, if you see onset during service, great. It means you probably have a pretty straightforward case, but you're probably not going to see that, unfortunately. So what you are going to see, a direct medical opinion about Nexus. Who's going to give that opinion? Ideally, the veteran's treating doctor. So if the veteran's being seen at the VA and is diagnosed with, say, major depressive disorder, and his personnel records from the Army, say, may not necessarily bear out that diagnosis, but may hint at it or point to it, it would be your job and our job to help you reach out to that veteran's treating doctor to get a statement about whether that doctor believes that there is a nexus. This may also be done not necessarily by the treating doctor, but by a medical expert contracted by the VA. So if the veteran's not receiving regular treatment, or their doctor, for example, isn't willing to write that letter, the VA may send them out for a contract exam. Obviously that's not the best case scenario, because we want, obviously the opinion to come from somebody that's seeing them regularly. However, there's ways that you guys can help, and we can help you help your veterans prepare for an exam like that if it comes to it. And again, what does that opinion say? It says, among other things, but it's important that it says that it's at least as likely as not that the event in service and current disabilities are connected. Again, that gets back to that burden of proof that I was talking about earlier, that 50-50 chance, the likelihood that the disability was incurred in service. And it's important to explain this to a doctor that you're working with, that they don't need to stick their neck out and say conclusively that the veteran has post-traumatic stress from service. The reality is a lot of the folks that we're working with have endured traumas both in service and outside of service, especially the folks that we're working with that have been dealing with long stretches of homelessness. So that being said, the doctor doesn't need to say that I think this happened in service and no other place. There just needs to be language that meets that burden of proof.
Are most of the doctors in the service, or are they civilians? Most of your treating doctors?
I would say that most of the treating doctors that I've worked with are civilians. And again, these are treating doctors that are at the VA. Some of them are vets, but most of them are not.
And so I wonder if they have sort of the same goals of reducing the benefits, they're part of that system.
So I think that's actually a great question, and I think it brings up why it's helpful that the VA is really separated out into two agencies, the benefit side of things and the healthcare side of things. I think that there's some concern with some doctors that, writing something like this might be a conflict of interest. It's not. We have, case law, literature kind of governing, regulations and guidance that say that it's not. But because of the true really separation between these, most of the doctors and the medical professionals that we've worked with don't seem to have that same either concern or cynical view that they're the, gatekeepers for the government's money. And so here's an example from a case that we've worked on about what that language might look like. And again, like I was saying earlier, when it comes to working with doctors to kind of, flesh these opinions out, we're more than happy to help kind of broker that relationship and move that process along with you. And then I'll just talk briefly about this kind of last example of nexus. There are certain disabilities where if the disability manifested not in service, but during a presumptive period after service, the VA will presume nexus. So an example of that is a chronic disability manifesting at 10% or more within a year of discharge. So any disabilities that involve psychosis or chronic psychosis would be a part of this. So schizophrenia, for example, a bipolar with psychotic features, depression with psychotic features, anything that manifests within a year of service no longer need to prove nexus. The other, I think, big example of this would be veterans that were exposed to Agent Orange during Vietnam or shortly thereafter. There's a list of disabilities that's actually in your handout that will be presumptively service-connected. The big one is veterans that were exposed to Agent Orange and now experience type 2 diabetes. The VA has recently recognized another kind of set of disabilities for veterans that were exposed to contaminated water at Camp Lejeune. So there's this kind of presumptive list of service connection disabilities is evolving. I don't think either of the cases that we've got today kind of fall into that category, but if they do, we can talk about kind of how to work with those. And again, I want to focus again on this as likely as not, or in other words, reasonable doubt standard. Because it's going to be so important for kind of the advocacy that you do and kind of the power that you can wield, knowing that this is a pretty low burden of proof and a pretty flexible one. And another quick example of what this could look like. You could very easily be working with a veteran who applied for service connection for post-traumatic stress and was denied previously. And maybe accompanying that denial, there was a letter or a opinion from a psychologist that they went to, like a contract examiner, that said, I don't believe this veteran's PTSD is connected to service. You may come back, you may appeal that case, you may reopen it. Maybe ideally you get a letter of support from his or her doctor saying that it is. And so you go to this hearing with two pieces of evidence relating to nexus, one that says no nexus, one that says yes nexus. Obviously you're going to want to argue that yours has more weight because maybe it's a doctor that's seen the veteran for multiple years or they've looked more closely at his file. But even if these two pieces of evidence are equal, the tie goes to the runner. The veteran is supposed to get disability benefits for service-connected, for post-traumatic stress in that case, because you have two pieces of evidence, and all things being equal, the veteran should get benefits. It's as likely as not.
And you're obligated to present the bad one?
What's that?
And you're obligated to present the bad one?
Well, in this particular context, the VA would already have it because it was used to make the denial in the first place. And so that's the reasonable doubt standard, and I'm going to transition over to Melissa to talk. Oh, yeah, absolutely.
Following up on that first question.
Yeah.
What happens when you have say you have a first medical opinion that says, I don't think this was going to reasonable nexus, and you go procure another one? And get rid of the first one and say, now this doctor says that there is a nexus.
Absolutely. I mean, it wouldn't. Yes. Are you saying in the context, in the case where like the VA may not necessarily have that
Yes.
first opinion?
Yes.
Yeah, absolutely.
Absolutely.
There are rules.
You don't have to produce it, or
No,
you don't?
absolutely that you can get the second opinion, and I think where he's going is that you don't have to worry about the battle.
Yeah, the rules for production of, again, we didn't touch on this earlier. This is at least in theory, a non-adversarial process. So this is,
Talking about the VA.
yeah, we're talking about the VA. You know, we're a room full of lawyers talking about how to win these cases, so that seems odd, obviously. But there isn't kind of the same rules with unfavorable evidence and production that may come with more traditional litigation, adversarial litigation.
So if they don't have it, we're not obligated to show it to them if we don't want to.
Correct.
And I can keep interviewing doctors
See?
until I get one that says.
Correct, yes. Ideally, especially if the veteran is being treated by somebody for post-traumatic stress, that's a doctor that has developed a relationship with the veteran and is going to be, I would say in 99% of the cases, favorable to that veteran. They may not be willing to write an opinion, but if they are, you're going to get something that's favorable. So the opinions that you would be pushing back against and trying to discredit would probably be these outside contract physicians, more than a private doctor that is saying they're willing to sit down and write a letter and then write a bad one for you. Not that it couldn't happen, but yeah.
Do we need the mic, or is that? Okay. All right. So, with that basic structure in mind, I'm sorry, I jumped in before we were. I was given my cue. All right. So with the three-element structure in mind, I'm now going to share some rules that modify that three-element structure. And I think these rules are particularly applicable in the cases that we're going to be, you all are going to be representing on. So one of your cases is a more traditional kind of combat post-traumatic stress case, and the other one involves a sexual assault that took place during the course of someone's service. So each one of the rules I'm going to talk about involves a mental health claim and post-traumatic stress, and the impact of the different rules the VA has created in this area. So a quick note starting with, you've probably heard John and I already alternate between saying post-traumatic stress, PTS, and post-traumatic stress disorder, PTSD. And that is in part because many folks in the mental health community who are providing treatment are advocating quite heavily to drop the D portion of post-traumatic stress disorder. The reasoning is that post-traumatic stress is a very normal response to abnormal circumstances. And when we add the term disorder to it, we're stigmatizing something that is already difficult to get treatment for or to encourage people to get treatment for. So we try to honor that. We defer to them and what they think is best, and we're still, though, learning different ways to say it. So know that we're talking about the same thing. The post-traumatic PTSD, or post-traumatic stress, is defined in the DSM. I believe the version 5 is out now. We need to update this here, but you can see a broader definition here. In mental health claims in particular, there are two sets of rules that implicate combat trauma and military sexual trauma as the basis for post-traumatic stress that I want to cover. And the reason is because they modify that three-element structure in a way that is very helpful to the veterans that we work with who might have post-traumatic stress from one of these two sources. So a significant part of that reason, right, as you can imagine, is that folks are not, taking extensive notes, as you might imagine, in the heat of a firefight in battle, right? We can't always prove to the moment and day, or even to the as likely as not standard, that somebody was in that mortar fire when they said they were, right? There's too much going on in those moments. Similarly, given the underreporting of military sexual trauma, given the underreporting of just general sexual assault, even in the civilian world, we often, too, do not see very clear records in a personnel file as to what happened. So that is why these rules have been modified over time to accommodate these particular cases for vets. So let's talk about both sets. So if somebody qualifies as a combat veteran, they will benefit from a relaxed standard of proof. So how does somebody become a combat veteran? We saw a DD 214 earlier today that involved a Purple Heart, right? There's a whole list of awards like Purple Heart, like Combat Action Badge, that will trigger an automatic assignment of the combat veteran status. As similarly, a certain military occupational specialties will as well. You see 2 listed up there, but there is a whole list. So you see a cite to the VA's internal operating manual that gives a fairly complete list of all of these things. And the reference is in there for you to use. And I should add, generally, in this part of the slide, in the substantive portion, we may not cover everything that's on each one of these slides. They're meant to be referential for you. So if I breeze past something that you want to know about, stop me and we'll jump in. So continuing on how you prove somebody is a combat veteran to benefit from these helpful presumptions that would fall into place. Say, for example, that they don't have maybe the traditional award and don't have an MOS. I talked earlier about a case where we represented a young woman who was a cook. So in that case, you can also prove combat status by the same standard that we get to prove almost everything else in the land of VA benefits, which is as likely as not, which you see up there. So we might pull buddy statements, we might pull unit histories, whatever we can to show that although this person's occupational specialties show that they didn't have a role that would be considered traditionally combat involved, they in fact were combat involved given what was going on at that time. On our case list today, I believe it's case number 1, it calls for representation of a Vietnam-era veteran who I think is going to have some of these very exact issues come up in the case about combat status. This will be particularly helpful to you. So I wanted to show the full form regulation about the relaxed standard of proof for combat veterans, and I've underlined the most important part of it. So I'll leave that up there for a moment for you to review, and then I'll break it down a bit more on the next slide. All right. So it breaks down to look like this. If a veteran has a post-traumatic stress diagnosis from a VA psych, an important qualifier there, it has to be a VA psych. The psych confirms that the claim structure is adequate to support a diagnosis of post-traumatic stress. That will generally happen if somebody does assign a diagnosis of post-traumatic stress, but for some reason the regulation calls that out explicitly. And the veteran's stressor, basically their declaration, is consistent with their time in service, right? They report an IED attack, or excuse me, an IED incident in Iraq or Afghanistan, something like purple Martians attacking me in Thailand, right, may be inconsistent with a diagnosis. So they add that to make sure the veteran's claim structure is consistent with their terms of service. Then the overall application for service-connected benefits for post-traumatic stress would be granted. So it's 3 much more simple elements, and you can see what it's really modifying there is the requirement that they prove something happened in service by an as likely as not standard. So they're loosening that up in recognition that for combat veterans, that's going to be a much more difficult thing to generally prove. Important to note here, too, that this only applies for post-traumatic stress cases. So if a veteran is diagnosed with, say, depression coming out of their combat, this relaxed standard will not apply. So a quick kind of more visual overview of how that changed the initial graph here. Right. And I want to transition now to talk about women veterans in combat status and also military sexual trauma rules, and give a broader definition to all of that and share how they similarly modify this structure for the cases. So we did talk about this earlier, about the challenges that we often see that women veterans face coming out of the military, given the now lifted but more traditional bar toward combat status. So VA would often deny claims based on, just disbelief that somebody, based on their gender and role, had seen the sort of combat that they claimed to have and certainly had in service. And this impacts a pretty high number of people, right? 14% of active duty service members are now women, and that number is growing. Certainly, this is an issue, and we're going to be asking you to pull in a case that involves a woman veteran that we continue to see in our community and that you will work on here. Also impacting women is what is often referred to as the epidemic of military sexual trauma. So these incidence rates that I report up here seem shockingly high. And these, I should add, are reports from the VA and Department of Defense. So these are their own internal mechanisms for the incidence rate of sexual assault. Still, it is considered wildly underreported, even in these incredibly high incidence rates and numbers. So in these cases, as you might imagine, right, because of the underreporting due to fear of retaliation, shame, a variety of very common responses to sexual assault. In recognition of that, there is an additional relaxed standard of proof, and that is captured in this particular portion of the Code of Federal Regulation. So it permits the use of evidence that is purely circumstantial to corroborate the sexual assault in service. This is different from the combat vet regulation, where the statement alone from that veteran would be sufficient, right? You kind of see the difference. I'll lay it out again in a more visual chart in a second. So here's the regulation in full. And it gives a few examples toward the center there of the types of circumstantial or corroborative proof that can be used. So it might be a behavioral change, right? One of the most common configurations that we see in these cases is that a service member is going along and doing quite well, moving through the ranks, and then suddenly their performance drops. They are looking like maybe a bad soldier. They are showing up late and intoxicated on duty. When what's really happening is they're probably dealing with the initial signs of post-traumatic stress post a sexual assault. So we might be using some of those write-ups from when they were written up for showing up late, were written up for not being in, maybe talking back to a superior in a way that wasn't acceptable. We might use those write-ups and those acts of discipline as our proof in those cases. And that is a perfectly acceptable way to prove up sexual assault. The regulation contemplates that very thing. I'll tell you, we've represented hundreds and hundreds of people at this point who are survivors of military sexual trauma, and I have yet to see one direct report in any personnel file. So we are constantly relying on this and constantly using what would be considered otherwise circumstantial proof to win these cases. They really call on us, as I think lawyers, to stretch our skills and our creativity and advocate for the folks that we're assisting. So I want to give you a few more examples of this when we've had to take F5, as we call it, and mold it to our cases. So in Ms. Jackson's case, I mentioned the use of what are called Article 15s, or non-judicial punishments in the military, where you're not going to get enough trouble to be sent to a court-martial, but they also might write you up for showing up late, whatever it might be. In Ms. Bell's case, we had a small notation of a brief and unexplained hospitalization that occurred. When we got the personnel records and shared them with that particular veteran, she had actually very little memory of this period in her service. And her psychologist had very clearly indicated to us that they thought that was because of the incidence of trauma. And so we had an unexplained period. We had the psychs share those reflections, and we were able to successfully win that case. Ms. Campbell, we had a woman who's being sexually assaulted by her direct supervisor or commander, and she started to make a series of requests for transfers to try to get away from him. These transfers kind of happened out of the blue in the military record and weren't really consistent with everything that was going on. And so we used that juxtaposition and argued that it fit the definition of F5 and that we could use it as this corroborative proof, and hence it met the incident and service requirement that it happened. So you see us really stretching this, right? And really pushing and advocating for our clients. And I'll tell you in these particular cases, because so often the women and men we represent have maybe not been believed before when they've told somebody. When we make these strives as advocates for them, it goes a long way toward those very, very important elements of recognition and justice in their lives and restoring dignity.
But even now, the VA's own records say 1 in 3 women, 1 in 6 men. Their own records, so it's probably double that.
Mm-hmm.
They still challenge the credibility. Even though their own records say that you have roughly a 30 to 50% chance of being raped if you're a woman and you
Yeah.
serve in the military.
They will still it's interesting, there's this weird cognitive dissonance that happens, right? They will recognize that statistically it's a problem, but when we bring cases that are, like an individual case where this has happened and we are proving this up using this types of evidence, the number of times the veteran's credibility itself gets questioned is absurd. They doubt the proof. These are cases that we often have to appeal. So we see this just, I don't know, irreconcilable and absolutely egregious gap. It's a huge part of the reason that we as advocates have a lot of work, and we're happy that you're taking on here one of these cases. All right. So again, here's that more formulaic kind of consideration for the military sexual trauma regulations. You'll see just the added element of that corroborative evidence that is in there. It's the one difference between this and combat status. All right. So we are pushing toward, I think, 7 o'clock. I don't have the clock in front of me. Can somebody confirm that? We are. Okay. Why don't we stop and take a break here, and then we'll come back in about, let's say, 5 minutes, and then we'll finish right on time and talk a little bit more about the cases that are in front of you today. Thanks, everyone.